So welcome back to our endocrine system series. We are going to be looking at part 5b, and this is probably our last slide in endocrine system. Maybe in the future might consider putting in some detailed bits of specific ideas, but for now this will be. Again, my name is Caroline Mutes. I'm a BSN, and I would love to take you through this with insulin. We'll be basically looking at type 2 diabetes. Stick with me, subscribe, like, and share. It's the small steps that matter. So, type 2 diabetes. Earlier on in the previous slide, in the previous presentation, we looked at type 1 diabetes, its complication, and its pathophysiology. So let's look at type 2. What happens to this? What exactly is going on in someone's body? One, this is due to not enough insulin. While type 1 they are not making, here it's just not enough. That's a possibility. But the other possibility is due to the insulin resistance. Your body is not accepting the insulin that you're making, or the insulin that you're making is bad. So this is also very common in overweight patients and older adults, which is different from the other one, which is common in babies or the young in children. So the uncontrolled glucose in blood sticks to the endothelial linings of the vessels, making them hard and narrow. So if this is the vessel, the endothelial lining, if you've ever put sugar in your hands, wet sugar in your hands, it sticks. And if you don't wash it off, it hardens. So it's the same thing that it does to the blood vessel. The more concentrations or the more sugar there is, the more it keeps depositing layers. And at the end of it, it becomes narrow. Okay? So it makes it hard and narrow, and this impedes on the blood flow to the peripheral, leading to kidney, vision, and venous insufficiency, poor wound healing, neuropathy, impotence, and so many other complications. But basically, blood supply is cut off to the end users because of the accumulation of the glucose. So let's look at the assessments of someone with type 2 diabetes. Their presentation will not be much different from the type 1 because, like I said earlier, it's the glucose that's going to cause all the problem. And this will affect all the organs in the long run. It will affect your immunity, it will affect your wound healing. So we will still have the 3 P's, the polydipsia, polyphagia, polyuria. If you want to know how these come about, please watch my previous presentation. It had the pathophysiology of how all these things really happen. This patient will present with a fatigue. One, the cells are not getting enough glucose. The glucose is too much in the blood, but the cells are not getting it. So they will be fatigued. They don't have a source of energy, source of glucose. They'll present with tingling and numbness because of the neuropathy that's caused due to the reduced blood supply to the peripherals. The fungal infections is because of the immunocompromise that happens, but also the recurrent UTIs is because of the sugar or the glucose in urine. The glucose in urine attracts microbes which can easily grow into infections. The poor wound healing, still the same explanation. There is reduced blood supply, nutrient supply to the peripherals. And in case of any wound, those nutrients are not available to enable the body to heal. But also the sugars that are in blood, even when it's carried to the peripherals, that blood is still highly concentrated. So instead of the blood carrying the nutrients, the blood around that area will instead pull out the fluids from the surrounding tissues and keep the wound wet. These patients will present with vision problems, and long term they will have retinopathy, nephropathy, impotence, cerebrovascular diseases, diabetic foot, myocardial infarctions, stroke. How do we manage these patients? In the previous presentation, I said the major management for type 1 is insulin administration. With type 2, the best thing you can do for a type 2 patient is diet. Diet and diet and diet. If you're able to play around the diet of a type 2 patient, you'll be able to keep their glucose levels in check. So advise these people to have a low carbohydrate meal. And where we talk about carbohydrate, we prefer the complex carbohydrates because this will take time before they are metabolized into glucose. Whereas the simple carbohydrates, immediately someone eats it, it's easily metabolized, hence increasing the glucose levels in blood very fast. These people are advised to increase their protein diet. These people are advised to increase their fruits and vegetables. Make sure that you look out for fruits that have very high sugars and know how to balance these. So, advise your DM patients to limit food consumption to between 1,200 to 1,800 kilocalories. In my country, this would be very difficult to actually teach someone because we rarely measure these things. However, the basic that we teach them is if you have a plate of food, a quarter of that plate should be the carbohydrate, and where we advise them to not eat more than their fist, the size of their fist. Then the other should be the proteins, and then the remaining should be fruits and vegetables. That's how we basically teach these people. But if you're able to measure, advise them to eat between 1,200 to 1,800 kilocalories per day. However, this should not be galloped in one meal. This should be divided into small meals. Like we had discussed earlier, the pathophysiology of these people, they easily feel hungry because the glucose is not getting to their cells. So they feel hungry. So if you decide to put 3 meals in a day, they are going to defy that because they will be feeling hungry. So the best thing to do is to give them small meals, maybe breakfast, a mid snack, something in the middle, something there before the dinner, and they'll be covered through the day. But as you're distributing their meals, make sure that they don't exceed more than the necessary kilocalories per day. That was important to emphasize. The second most important thing is exercise. While these people are controlling their diet, most of them are obese, overweight. So you need to advise them on how to cut their fat and how to cut their calories, how to use up their glucose. And one of my teachers said that every time someone exercises, it's like they're getting a shot of insulin, because what insulin does is to make sure it gets the glucose out of the blood into the cells. Likewise, the exercise will make the body use up that glucose. So before they exercise, teach them that you need to eat before exercising because they are at a very high risk for hypoglycemia if they exercise before eating. 2. Exercise when your blood glucose levels are at peak or at highest. 3. Establish a routine. Exercise with rest in between. These people need to rest as they are exercising. They shouldn't do marathon exercises as a normal person should. And whenever they are exercising and they start feeling signs of hypoglycemia, they need to stop immediately because they will collapse. They'll collapse because they don't have any more glucose to use during their exercises. So as you're telling them to exercise, make sure that you emphasize these important points to them before they take up their routine. Medical management, that's the other type of management. So these people are given oral hypoglycemics, and make sure that they adhere to these. Once they are started on them, make sure that they adhere, because these work by reducing the glucose levels in the blood that the body is failing, but they will also improve how your body responds or produces the insulin. There are some people that are given metformin. Majorly, metformin works to reduce the HbA1c. Like I discussed in the first presentation, HbA1c is basically a percentage of glucose molecules that are bound to the hemoglobin molecule, and it helps you assess your adaptation to this in a period of 2 to 3 months. So it's not like a random blood glucose level, which will tell you that your body is adapting or is using up the glucose in this way, but this will tell you for a period of 3 months. And then when everything fails, these people are started on insulin. In the earlier slides, we said there is rapid, short, and intermediate, and long-acting insulins. So know which kind of insulin your patient is on. Know when to have their meals brought on time. If it's rapid, they should be given this rapid when they are eating their meal. If they are going to bed, rapid, short, they are not advisable to be given to a patient because they will easily die in their sleep. Instead, give them long-acting insulin, because we know it doesn't have a peak and it takes a very long time to work. By the time these patients wake up, they are able to have something before they run into hypoglycemia. So, the major complication in type 2 diabetes is what they call the hyperglycemic hyperosmolar non-ketotic syndrome, or HHNS. I know you've heard about that. So this literally what they are telling you is hyperglycemic, meaning it's highly concentrated with glucose. Hyperosmolar is high concentration. Non-ketotic syndrome, it means the body is not producing any kinds of ketones. So whatever symptoms that you were presenting with earlier in DKA, where we are producing the ketones, here you will not have them. So what is HHNS? It is a life-threatening complication of uncontrolled diabetes mellitus. This syndrome is characterized with severe hyperglycemia and a marked increase in serum osmolarity, clinical evidence of dehydration without significant accumulation of keto acids. It's basically dehydration without fat metabolism. While in DKA, the major thing was use of fats to produce the glucose, and hence we had ketones being produced. Here we are not using fats for any source of glucose, so it's basically dehydration. When we have our DKA, if we remove our K and A, because K and A are the symptoms of ketone production, we'll remain with dehydration. So in HHNS, the major thing you need to know is it's dehydration. This patient is severely dehydration. In your management, manage dehydration and you have this patient back. So let's look at our other condition. We said if we have too much insulin, we get hypoglycemia. If we have too little insulin, we have diabetes mellitus. So let's look at where we have too much insulin. If we are looking at hypoglycemia or too much insulin in the body, let's think about someone who is drunk and someone who is in shock. these patients will present in a similar way. If you've ever seen someone who is drunk, they are staggering, they are sweating, they are confused, they are talking, their speech doesn't add up. And if you've seen someone is in shock, they are literally shivering, they are sweating, their BPs are quite very low. So think about someone who is drunk and someone who is in shock, and you have all your symptoms of hypoglycemia. So what is this? It is a condition that happens due to too much insulin secretion, causing a reduced glucose level in blood. So the RBC is usually well less than 70 milligrams per deciliter. So the causes: one, it could be because of the too much insulin. One, you're administering too much of it, other bodies making too much of it. Maybe you have a tumor in the producing cells. Two, the other cause of hypoglycemia is too much exercise. Like I said, every time you exercise, count that as a dose of insulin. You're literally getting the glucose out of your blood. So every time you exercise, you're at risk of hypoglycemia. The other cause is starvation. You're not putting the glucose into your body. How do you expect to get it in your blood? So if you're starving yourself, you're at a very high risk of that. Then the use of oral hypoglycemic medication. We say their main role is to reduce the glucose levels. So as you're doing all this, you need to monitor this patient very closely. You need to monitor this person very closely for the signs and symptoms of drunk in shock, signs and symptoms of hypoglycemia. So let's summarize drunk in shock. This person will be cold, they'll be clammy, they'll be confused, they'll have headaches, they'll have nervousness, they'll have nausea, slurred speech, they will present with a lot of hunger. You're not eating, your body is starving. They'll present with sweating, tachycardia, paresthesias, sleepiness. Their consciousness goes on reducing with time, and very soon they run into coma. So note, hypoglycemia, you're literally drunk and you're literally in shock. So you have similar symptoms. Management. How do we manage these people of hypoglycemia? So if I don't have the glucose, the best thing you can do is to give me the glucose. So you can give an intravenous bolus of D50. Also, the intramuscular hormone glucagon helps break down the stored glucose so that it's increased in blood. So if the person is at home, advise them to inject themselves with glucagon, because that's easy. There's no way someone tells you, I'm home, I'm stuck, and this patient is hypoglycemic, and you tell them, please give IV bolus. First of all, they are not trained to give IV medication. So the best thing you can do is ask them, do you have your glucagon on you? If they tell you yes, tell them to give themselves IM, or tell the caretaker to give them an IM. It will help them as you're calling for help. The other management is the 15-15 rule. Some people quote the 2-15, some people quote the 3. I'll explain the 3-15-15 rule. 1, have a snack of about 15 grams of carbohydrate every 15 minutes. That's after testing your RBS and you've realized this person is hypoglycemic. Have a snack, and this carbohydrate should be a simple carbohydrate because we want to get glucose as fast as possible into the blood. So after that, wait for 15 minutes and check the RBS again. If the RBS is still less than 70 milligrams per deciliter, advise this person to eat another snack of 15 grams of carbohydrates. Still, this is simple carbohydrates because we want to get the glucose as fast as possible into blood. Then they can add on a complex carbohydrate or a protein, and that is our 15-15 rule. 15 grams of carbohydrates. Next 15 is the 15 minutes of waiting, which is this 15 minutes of waiting after the 15 grams of simple carbohydrates. And then if it's less than 70, it's another 15 grams of carbohydrates plus a complex carbohydrate or protein. And then you can continuously monitor this patient. Again, thank you for listening. This has been longer than I thought it would be, but I needed to get the point home. Thank you for subscribing. To those that have not subscribed, please subscribe. We are going to be sharing more on our platform. Very soon I'll be discussing some bit of pharmacology. I'll be simplifying it for you to pass your exams and so many other topics that we'll be discussing. Thanks again for listening. Watch, like, share, and subscribe at Life with Nance Carol. I love you all. Stay blessed.